You hear the word shock, and you probably think of a surprise party or some startling news. But in a hospital, that word means something else entirely. It's a code red, a medical emergency. It means a patient is in a race against time, and every single second counts.
And that is really the core question, isn't it? What happens when everything just starts to shut down? Because shock isn't really a single disease. It's more like a catastrophic system failure that can be kicked off by a whole bunch of different things. To get it, we've got to go small. We have to look at what's happening at the cellular level. Okay, so here's the scientific breakdown. But what does it really mean? It all comes down to one thing: oxygen. Your body's cells are being starved of it. It's like they're suffocating. And when your cells can't breathe, they can't work. And if that isn't fixed, and fixed fast, your organs start to fail. I love this analogy because it makes it so clear. Just picture every single cell in your body as a tiny factory, working 24/7. Oxygen is the electricity that keeps all the machines running. Well, in shock, the power grid goes down. One factory goes dark, then another, then a whole city block. That's your organs failing. It's a domino effect, and it's devastating. Okay, so to fight this enemy, you first have to know who you're dealing with. Because shock isn't a one-size-fits-all problem. It turns out there are 4 main ways this whole cellular power failure can happen. And wow, this chart really lays it all out. You've got your 4 main categories, right? Hypovolemic, cardiogenic, obstructive, and distributive. But then you see how each one branches out into all these specific causes. Everything from massive blood loss, to a heart attack, to a severe infection. The first, most crucial step for any clinician is figuring out which one of these pathways they're on.
Let's break this down even simpler with some really clever analogies. For hypovolemic shock, think of it like your body's fluid tank is empty. Not enough blood, not enough fluid. For cardiogenic, the pump, your heart, is broken. It just can't pump effectively. In obstructive shock, there's a physical blockage, like a massive blood clot, stopping blood from getting where it needs to go. And finally, distributive shock. That's where the pipes, your blood vessels, are either too leaky or way too wide, and your blood pressure just plummets.
So you're in a chaotic ER. How do you even begin to figure out which of these is? Well, sometimes the first clue is as simple as touching the patient's skin. See, most types of shock makes the skin cold and clammy, what we call cold shock. But one type, septic shock, often does the complete opposite. The patient's skin is warm. That one simple physical sign can immediately point a doctor in the right direction. It's a huge clue.
All right, the patient is crashing, the clock is ticking, there's absolutely no time to waste. The response has to be lightning fast, it has to be systematic, and it has to be decisive. And there's a protocol for that, a way to turn that chaos into a structured plan of attack. And this is the battle plan, the minutes protocol. The most important thing to see here is the timeline at the bottom. 0 minutes, 10 minutes, 20. This isn't some leisurely diagnostic puzzle. It's a frantic, minute-by-minute fight to stabilize the patient and figure out what's wrong before the damage becomes permanent. The name itself, MINUTES, is an acronym that spells out the entire game plan. M for maintain, IN for infuse and investigate, U for ultrasound, TE for treat the etiology, and S for stabilize. Let's just quickly walk through what each of those steps looks like in the heat of the moment. The second a clinician suspects shock, that clock starts. And that very first minute, just 60 seconds, is all about the absolute basics, the ABCs. Is the airway clear? Is the patient breathing? Is there any circulation? Forget everything else, because if you don't have the ABCs, you have nothing. You have to keep the patient alive before you can fix them. And during that same first minute, they're also on the hunt for what they call rapidly fatal problems. Things like massive external bleeding or a collapsed lung. These are things you can see and fix right there at the bedside, instantly, and they could be the entire problem. Now we're in the first 10 minutes, and this is where things get really intense. You're doing 2 critical things at the exact same time. You're trying to get that dangerously low blood pressure back up, while also drawing blood and running every test you can to figure out what's going on. It's treating and diagnosing in parallel. But here's a huge decision point. How exactly do you get that blood pressure back up? For years, the answer was always give IV fluids. Just pour them in. But what if the pump is broken, like in cardiogenic shock? All that extra fluid could actually make the heart fail faster. So now there's a big shift towards using drugs called vasopressors, which squeeze the blood vessels much, much earlier. And while all this is going on, the lab is in a race of its own, trying to answer these critical questions, like, right now, how much oxygen is in the blood? What's the lactate level? That's a huge marker for cellular stress. Are they anemic? And what's the heart doing on the ECG? Every single result is another piece of the puzzle. But you know what? Maybe the single biggest game changer in diagnosing shock doesn't even come from a blood test or a lab. It comes from a machine that a doctor can wheel right to the bedside to get a real-time look inside the patient's body.
I mean, this quote just nails it. Point-of-care ultrasound, or POCUS, has completely changed the game in emergency medicine. It's like giving doctors X-ray vision. They're no longer guessing about the pump, the tank, or the pipes. They can literally see what's going wrong right there, right then.
And this is exactly what they're seeing. It's incredible. They can look at the heart and see, is it beating like crazy but looks empty? That's probably an empty tank, hypovolemic shock. Or is the heart full but barely squeezing at all? That's a broken pump, cardiogenic shock. They can see fluid where it shouldn't be, find clots. It turns a guessing game into a visual diagnosis.
Okay, so now you have clues from the lab, you've got this amazing visual from the ultrasound, the fog is starting to clear. By the 20-minute mark, the goal is to pivot from just general life support to treating the specific root cause, the etiology. That means starting powerful antibiotics if it's sepsis, calling a surgeon to stop the bleeding, or rushing that heart attack patient to get their artery opened.
So, the immediate crisis is under control. The fire is out, but the job isn't done, not even close. Now comes the final, crucial phase of the protocol, carefully managing the patient's recovery and making sure you don't cause any more harm.
This last part is all about the details. It's a really delicate balancing act. You have to make sure the organs are getting just enough blood flow, but not so much that you flood them with fluid. You're correcting all the chemical imbalances in the body. And then, slowly, carefully, you start to pull back on the support as the patient's body starts to heal itself.
So, this minutes protocol, it's a massive step forward, right? It brings order to one of the most chaotic situations in all of medicine. But it just gets you thinking, what's next? Could AI help read those ultrasound images even faster? Could new sensors predict who's about to go into shock before they even crash? The race against the clock is never really over, but new technology might just give us an even bigger head start.